Thank you, Kathy. Hello, everyone. Good afternoon, good morning, good evening, depending on the place where you are. It's a true pleasure and an honor to co-chair this session together with Professor Michael Connolly. And thank you very much, Kathy, for organizing this. And most of all, it's an honor to be able to introduce Professor Eduardo Bruera. Professor Eduardo Bruera obtained his medical degree from the University of Rosario in Argentina. He trained in medical oncology, and in 1984 he relocated to the University of Alberta in Edmonton, Canada, where he directed the clinical and academic palliative care programs until 1999. At that time, Dr. Bruera joined the University of Texas MD Anderson Cancer Center in Houston, Texas, USA, where he currently holds the FT McGraw Chair in the treatment of cancer, and he is also the chair of the Department of Palliative, Rehabilitation, and Integrative Medicine. He's also Professor of Medicine and Medical Director of the Department of Supportive Care Cancer Center. Professor Bruera has received more than 30 honors and awards due to his extraordinary work and also to his dedication to supportive and palliative care for patients with cancer. And if you allow me, I would like to highlight the second Vittorio Ventafrida Memorial Lecture Award from the European Association for Palliative Care in 2012. Professor Bruera will now share a 30-minute presentation on integrating early palliative care for patients with cancer, the evidence and the challenges. And once again, thank you very much for being here with us. Professor Bruera, the virtual floor is yours. Thank you very much.
Thank you so much, Sandra. Muito obrigado por essa apresentação. And also Michael and Kathy, and of course AIIHPC, and of course the All Ireland Institute, Erin Gobra. My mom, my Irish mammy has given me a strong mandate that I should never say no when I get committed by Irish forces, and therefore I'm delighted to be here today. And we're going to be talking about a subject that is close to our hearts, and it's a little bit complex, and therefore we're going to go fast. So I'd like you to fasten your seatbelts so we can go through a review of where we are in this system. We all know that our cancer patients suffer multiple devastating symptoms. This patient had pain due to bony metastasis, had cachexia, profound fatigue, depression and anxiety, and a lot of these symptoms come as a package, and the patient suffers from those symptoms in a combined way. Multiple symptoms happen at the same time, and the family is also ill when the patient is ill. And that is basically what we started to do. It was initially a fringe movement. It started in the 60s. So we should be seen as with tattoos and nose rings. We were a protest movement, initially taking patients when their disease was not treatable to places where we could take care of them. And in the meantime, mainstream medicine was inventing critical care medicine, emergency medicine, multiple other specialists, including oncology. They're all younger than we are, but we were born out of wedlock. And so it took us longer to be adopted in the healthcare system and also to be adopted in the academic system. We also know that a person suffers not just because of their lung cancer and their treatment, they suffer from multiple personhood issues that contribute to their ESAS distress and well-being and contribute to utilization in healthcare. And so we deal with suffering. That is what we treat, and that's by nature very complex. There are red areas that we need to address to be able to move into the important green and blue areas, and we have developed a body of knowledge on how to navigate this complex structure. But the most important concept is that this is complex. The oncologists, interns, family doctors have failed to relieve the suffering before they send us a patient. By the time they send us a patient, they already tried some things that didn't work very well. And we know that there are domains in what we do, domains that are physical, psychological, social, spiritual, practical, end of life, loss and grief. And there are groups of people. There are disciplines that interact. and some disciplines are more red because they do more of the physical. Some disciplines are more green because they do more of the social. But a lot of the disciplines have different colors to them. They have different aspects that they can deal of those patients' needs. We know that each of these elements in the patient's care requires that we work on specific rectangles and dimensions. And we evolved over the years. We started close to end of life, days of life. Then we moved on, and Balmount created the World Palliative Care Unit. We moved into inpatient facilities in acute care facilities rather than the community-based centers, and that moved us from days to weeks. Then we started doing outpatient palliative care in the 90s, initially in Canada, and that moved us from weeks to months. Then with Jennifer Temel's work and a lot of work that came later, we moved into earlier palliative care, so the outpatient but earlier. And of course, now COVID has turned into the telemedicine world. And I think that is where we are right now. And basically, we have moved from emotions-based to experience-based to evidence-based. And we are now at a stage of evidence-based medicine. So our definition based on systematic reviews is hospice care is very close to the end of life. Palliative care is close to advanced disease. Supportive care is close to earlier stages of the disease or earlier stages of the advanced disease process. And teams are extremely important. As you can see, this is the team we had. You can see this was taken about 3 or 4 months ago. And basically, this is the team where we used to work in Canada. The assessment of the distress can be done very easily. And there have been a number of trials that have been documenting that palliative care works. And I would like to spend some time discussing with you that we have a body of evidence right now based on randomized controlled trials that supports the presence of early and outpatient palliative care. The study from Temel that was the first to show some wonderful things was a randomized controlled trial comparing patients with lung cancer receiving integrated palliative care by a specialist team versus routine oncology care. And they found those differences in quality of life, resource utilization, and they found that there was better quality of life, better rates of depression and anxiety, less aggressive end-of-life care, and improved documentation of end-of-life. They even found this survival advantage that other studies have not reproduced in the future, and it was a secondary outcome of the study. So, but what we learned is, for sure, there's been no study showing that early palliative care shortens in any way survival of the patients. Now, the integration, they're required to understand what were they having? Do they feel that the treatment was accurate or not? And they found that it was. With early palliative care, the patients were more likely to retain and develop adequate assessment of their prognosis. They knew what was going on with them better when they received early palliative care in that study. So we learned that there were early palliative care patients received different things from the patients that did not receive early palliative care, including no chemo near the end of life, better understanding of their disease, and less inaccurate prognosis. Zimmerman from Canada did this randomized controlled trial also on patients with advanced malignancies, a number of cancers, palliative care consultation by specialist team and follow-up versus routine. They measured all these elements you can see here, and they found that basically there was an improvement in a lot of them when you followed up on those patients at 4 months and also at 3 months. There were significant improvements, as you can see in the FACIT quality of life, ESAS, FAMCare, and basically they concluded that there was an advantage in doing this. Marco Maltoni in the European Journal of Cancer did this study with pancreatic cancer patients randomized to integrative palliative care or routine oncology care in Italy. They used similar tools as everybody else, and they observed an improvement in multiple variables in the patients who received palliative care as compared to usual care. Jennifer Temmel repeated the study now in lung plus non-colorectal gastrointestinal cancer, again, randomized to integrated care versus routine care. The tools were the same that were shown before, and there was a significant improvement that was more dramatic for the lung patients, probably because the lung patients were a little bit more advanced in their trajectory of illness as compared to the GI patients who were a little bit earlier in their trajectory of illness. So they did not have such a bad series of problems that could be fixed. And when you have less problems, then you see less difference when you fix things. The improvement in prognostic understanding was common and happened very much in both groups. And understanding of disease is important in decision making. Grudson et al. Did this randomized control trial in inpatient palliative care consultation versus routine care. This was inpatients that were seen and were having a number of variables, and they found that there was a better health-related quality of life, but there was no difference in hospice use, hospital days, or ICU admission. And why is that? Because when the patient gets referred as inpatient for the first time, many bad things have already happened in the outpatient setting. So that was later type of access for the patients. El Jawahiri did this study that was wonderful in stem cell patients, and they randomized the stem cell transplantation patients to palliative care during the inpatient versus routine care, and they observed improvement in all these variables: quality of life, depression, anxiety, and overall ESAS symptom burden improved in these patients when they received integrated palliative care. And also in myeloma patients, they did the same type of study, randomized control trial, inpatient palliative care in myeloma patients, acute myeloid leukemia patients. The leukemia patients randomized to palliative care versus routine. Again, quality of life, depression, anxiety, lower PTSD development after the aggressive therapy. So overall, there was a very significant improvement in patients as well as preferences near the end of life. Moens-Gronvold did this randomized control trial in which patients were randomized to palliative care versus routine oncology care, and they observed that there was no major change in a lot of the variables. But what happened in this trial is that the intensity of the interaction, both face-to-face and telephone, was not very high. So the adherence to the interventions by the patients was not very high, and that may have had impact on making a difference because they did not get to see them very much. There are systematic reviews. We've done some other groups have done, and what do we find in systematic reviews? Quality of life generally improves, symptoms generally improve, and survival generally does not improve. But again, survival does not deteriorate. These are systematic reviews, 15 studies, 11, 12, 5, 2, and 7. So these are all systematic reviews of clinical trials. What does the literature say? Well, there you have. When you have interdisciplinary, specialist-driven groups, you see a lot of green, showing you that for quality of life symptoms, depression, satisfaction, there is an improvement. When you see physician alone, there's a little bit less of green here. When you see APN-led, again, less green. When you see RN-led, less. And in primary care, unfortunately, not much evidence that it does make a difference when you do primary palliative care. There are methodological challenges. Negative outcomes if the interventions are not robust enough. As we said before, if you don't see them enough, if you don't have enough dose of palliative care, you cannot really compare very much. And then adherence is important. So there are methodological challenges we need to work at. What do we know so far? Early palliative care by a specialist-driven team reduces symptom burden, improves quality of life, improves or does not reduce survival, and very important for your administrators, saves money. What does not work? Very simple interventions. Just a couple of calls, a couple of meetings, that doesn't usually work. Primary palliative care, not a lot of evidence. Single interventions, generally negative. So why do patients feel better and perhaps even live more? Well, it might be because improved symptoms increase adherence to cancer treatment. That's what our oncology colleagues would love to know. Poorly managed symptoms kill, and we know that suffering kills. And finally, you might spare people aggressive treatments that might not need and might end up shortening their life. Are we getting to the cancer patients in time? We're concerned about these. And in the 2000s, we looked at more than 3,000 patients. We followed them up continuously. Our program was wonderfully growing 10 to 20% per year. And we found the time from first palliative care consult to death, unfortunately, was 42 days. The oncologist knew this patient was going to die 250 days before death, but we only got that patient 42 days before they died. And we looked over time. The program was growing very nicely, but the number of days between the first consult and death were not getting any longer. They're actually getting shorter. And we said, oh my goodness, we're not really getting them earlier. And the oncologist knew a considerable amount of time that this patient was going to die. There are the Kaplan-Meier curves. And so we knew that for leukemia and other liquid tumors, it was even worse than for solid tumors. And so we knew we have a problem of very late referrals. And we tried to understand, could this be a name? In an MD Anderson being such a big place, we did 100 medical oncologists and 100 advanced practice providers. And here you can see the population that we studied, about 140, very excellent response from them. And if you look here, you can see that near the end of life, the great majority of them were prepared to send us a patient to a service named palliative care or named supportive care. But as you moved earlier, we didn't tell them anything else. We just gave them the name of the service. They were much less likely to refer patients to a program named palliative as compared to supportive care. And that dropped very significantly for all these categories: early cancer, no active of disease, receiving active therapy. The patients were less likely to be referred. And when we asked them why, well, 23% of them thought that the name was a barrier, and 44% of them thought that the service name reduced hope on the patient, because if they Googled palliative, they would get hospice and death and so on. They all perceived anonymously that we were doing a great job, but they were not so likely to send us a patient. We repeated this study more than a decade later, and guess what? We found the same type of attitude by those clinicians with regards to the name palliative care. They found that in a patient newly diagnosed with cancer, both hematological and solid tumor oncologists were much more likely to send a patient to a service named supportive care than to a service named palliative care. And they again felt that the barrier was the name, 36% of them, and 60% that it decreased hope. And not the same thing for supportive care, much better attitude towards the name supportive care. So there is a problem with hope among those who have to send us those patients early. So we had an approach of goals of care that we called goals of CAR, integrated model, and changed the name over the outpatient center and mobile team. And so the goals of CAR is simply that in Texas, if you are alive, you have a car. And then we said, you get a car, you buy the car, you have goals, but you might choose to be totally unrealistic and negate things, or you might be realistic without changing your goals anyway. You wear a seatbelt, you buy insurance, you lock your car in the shopping mall, and then you do the same thing with your car, but those precautions you've taken change your outlook very dramatically. And the same thing you can do with your cancer. You can have goals of cure or life prolongation and make absolutely no discussions or provisions, or you might do those. And that's what supportive and palliative care allows you to do. And basically, you deal with who's going to move on with me, who am I going to move with, who's going to make the monies, all the issues of my care, and where do I draw the line? When do I want ICU? When am I going to stay away from the ICU? So the goals of CAR was accompanied by an education of our colleagues about the integrated model. If they try to do it alone, they're going to leave a lot of the blocks of care not well done because the person they don't have the time to do that. If they do a congress, they create conflict. They invite so many people to the party that it gets messy. And an integrated role with us then judiciously referring to services as necessary might be a great model. When we implemented that with the name supportive care, we rapidly saw a 41% increase in referrals within the first 6 months. And not only referrals were early because they were moving earlier in time, but also a lot of colleagues that were not referring as much started referring. And there you can see the changes in the Kaplan-Meiers of the patients after changing the name to supportive care. And you can see that the growth at that point, that was around this time, started being in the double digits from being in the single digits before. It moved well into the double digits. And there you can see the outpatient growth, again, moving rapidly into the double digits. Now, to keep those encounters fixed, these are the encounters per clinician per year, to keep those encounters fixed as the program was having this exponential growth, the red line was crucial. That is to create the jobs, to hire the people so that these bar graphs would stay around the 1,200, knowing that above 1,200, burnout starts to happen. But the other thing we learned is that patients were going to need to be seen more times. As the years went by, we went from 2.9 follow-up visits to 5, and now we're going to 7 or 8 follow-up visits, and you need the space in clinical positions and space physically to see those patients. Are we receiving the patients early enough in the United States? We did those 2 surveys in 2009 and 18. There's about 50 comprehensive cancer centers in the nation that are the most sophisticated cancer centers, and 1,500 non-comprehensive cancer centers. In the more sophisticated centers, you can see that outpatient clinics in the decade from 2009 to 18 increased quite dramatically. But where the vast majority, 80% of the patients get treated, they grew, but not dramatically. Most of them don't even have an outpatient clinic to see these patients. Now, the inpatient teams were very high, and they kept very high, and the other ones improved a little bit. Palliative care units, not good. Very small have palliative care units. When we moved on into the presence of inpatient consult teams and 24/7 availability, the same thing happens. For inpatient teams, we're doing reasonably well. For consults, we're not doing so well for inpatient palliative care units. And the days of referral have increased. And of course, the number of referrals per month have increased in all the settings. Fellowships are concerning. Many of them do not have fellowships, yet the comprehensive cancer centers do. Palliative care fellowships in the rest are not very much available, although oncology fellows are there. And the saddest thing of all is mandatory rotation for medical oncology fellows continues to be lagging. And that is important because the people who learn what we can do for the patients are the ones who are likely to send you the patients later. So palliative care is more available. Only 1 in 3 have an outpatient center. Less than 1 in 4 have a PCU, and the barriers are all financial. So we have criteria for sending the patients. We developed Delphi and major criteria, and you can see here that the majority of the criteria are need-based, and there's a couple of criteria that are time-based. But if you look at needs-based criteria, there you have a series of criteria you can apply to your institution or system that will allow you to decide if you are integrating or not. And then you have 2 times time-based criteria that you can also apply to these patients. So 36 minor criteria, but don't worry about them. The 11 major criteria are more than enough. 9 of the 11 are needs-based, only 2 are time-based. And most important of all, you need to harmonize those criteria with the resources. If you don't see that little red line go up and hiring more people, all you're going to do is burn out your clinicians unnecessarily. So harmonize the criteria with the resources you need to be able to provide the access. And so what do the patients think about this? The patients want to be referred when their symptoms are not well controlled, when they have problems with depression or anxiety, and when their family is having emotional distress. This is what the patients are telling us they want. They're not so interested in time, they're interested in need. When we asked our patients if the referral was in time, 72% of us told us in 2017 that it was in time. 5 years ago, 80% had told us that it was too late. And so big change. And it was about 7 months before death. 6 to 7 months before death, most patients seem to feel that the referral has been timely. When we asked them how was palliative care, anonymously, they really liked it. They really felt it was useful to them. They recommended to others. So when you refer them 7 months before they go to the outpatient, they really like it. The outpatient center is person-oriented care, and administrators hate it. They hate that we have outpatient centers. They tell us you have to have a waiting room, and so we make sure that we don't have a lot of dying patients, mutilated patients, cathected patients, depressed patients in front of each other. We keep it always empty. And for the few that are there, we pass them videos out there. We keep an eye so that we keep it empty all the time. We go and visit them in their rooms, and we do all the care in those rooms. We have the art in the ceilings where the patients in stretchers or in wheelchairs can see it rather than on the walls. And there you can see it there. We start the care with the clerk at the front office. That's a clinician. We think that the suffering can be assessed and relieved. And they need to understand that some people are going to come angry and depressed and sad. So they're part of our clinical team. Of course, the clinicians are important. We call this a fluoroscopy room because otherwise they take it away and do something that makes money. And this is where conversations happen and the environment needs to be there. Full beds rather than examining tables and plenty of chairs. Assessments by the team. The ESAs done before the encounter or electronically. The MDAS, the cage when it's necessary. The comprehensive history and triaging. They can phone us at any time or we phone them to see how they are doing because many of them won't phone us. Our counselors are present in presence, but before even COVID, we had 18% of them doing it by FaceTime or video, and they're there in person or in video to address our patients. We encourage walk-ins. Patients need to be able to walk in because they have worse scores for suffering and they're on higher opioid doses when they walk in. They don't abuse the system, they just need to see us. When COVID started, this hospital at Anderson came to a stop. Almost everything stopped. We had the advantage of hurricanes. Yesterday, we had a hurricane going by our city and the hospital stopped. We didn't stop. We contacted all the patients that were scheduled to come to see how they were doing, to get them medications, to get them support. And when there were no medications in the drugstores, no problem. What do you have at home? Open your drug cabinet. Let me work with you into what you can take the next few days until things get better. And we looked at patients before and after the transition to virtual care. And there you can see 4 weeks before, we saw 723 patients. The moment we started the transition, we did it over 1 week. And we saw more patients at the end of that instead of less. Many of our other oncology teams closed down. We actually increased the work. What we learned is that we saw more patients during the 4 weeks after the transition, that the visit method dramatically changed into virtual, and the assessments were maintained. The assessments could be done, the ESAs, the MDAS, all the assessment, even the nursing assessment could be done in depth in those patients virtually. Here you can see that the transition happened very rapidly from in a large proportion of them still being in person to 1.8% being in person very rapidly when it was necessary. We learned that transition is important because it keeps care when others close. Limited inpatient presence achieved healing for the patients, the families, but also kept the integrity of our teams. Many other teams had to close down because of contagion. We did not, fortunately, have that problem. It decreased our no-shows, but it decreased our walk-ins. People are less likely to walk in virtually than they are in person. It needs to stay. Should we need national, European, Asian license across states? We need to train our trainees to do appropriate telemedicine care. And what do we know about palliative care integration? When you see the patient as an outpatient, you achieve a lot of outcomes that are superior as to when they send you the patient as an inpatient. Very easy measure. When did they send me this patient first? As an outpatient, I'm going to prevent a lot of unnecessary aggression. They send it to me as an inpatient, less likely. So it is associated with better outcomes. It can be examined in many ways, and it appears to be limited even today. The dream is a patient with these characteristics goes to this center and gets a whole bunch of services of a different nature because that's what their doctor wants. Another doctor sends them to another place. In this case, these two doctors send them nowhere. And in this case, this doctor is enlightened and sends them to a supportive care center where they receive a whole package of care, and the follow-up is organized as necessary. The package might be a common regular package for 100 patients a day, but this 32-year-old patient with cervix cancer needs a slightly different follow-up package as compared to this other patient with other problems. So automatic criteria, in my view, are unnecessary to send the patient. They might be useful to inform the oncologist that there are things happening to this patient that you might want to pay attention. And then the number one is this integrity of the oncologist's relationship with the supportive and palliative care team that makes the patients come. There's a lot of unnecessary suffering that can be alleviated, and it can be alleviated early if they give us access. Early integration improves the clinical outcomes, reduces the cost of care, and probably might prolong survival in some of them. It should happen in the outpatient setting. Each institution needs to decide the threshold for integration according to clinical capacity. They cannot kill you. And better small number than large number bad. So provide extraordinarily gifted care to a small number of patients, if that's all the bandwidth you have, instead of providing superficial, poor care, just changing the laxative to a very large number of patients because they're mandating that. So that was my short, well, fast, not so short, but fast presentation. And now I think I would love to see if our chair persons would like to take it from here.
Thank you so much, Eduardo, for a fascinating trawl through the work you've been doing over the last number of years, building the evidence. And I suppose one of the common questions that's come through prior to your presentation, and which I think is reflective of where we all are, is how do you ensure early referral, and how do we encourage colleagues to refer appropriately and early if we can? We seem to be getting it right with some patients who have a diagnosis of cancers, but not so much with maybe those with hematological cancer-related disease and others. So how do we actually get our colleagues working in oncology to make that early referral, given that there is substantive evidence to show its benefit?
Thanks so much, Michael. I think the evidence is clearly there, but that's not really going to make the change in the culture happen that easy. And the change in the culture needs steps to happen. And so the first is going to be denial. They don't need to come that early. We don't need them at this point. And I wrote a paper on that several years ago, and that would be the first stage. The second would be polyphobia. If I send these patients as outpatients, are they going to be talked out of getting my cancer treatment? Am I not going to be able to do my clinical trial? Are they going to be not abiding by my desire to treat the cancer appropriately? And then to discuss denial is very easy because these patients are suffering. Just go do an ESAS, do an assessment of those patients, and you'll easily dispel the fact that those people are having a great time. They're not having a great time, even though they're in active cancer therapy. The second point, that is the polyphobia, how to address it. The way I did it first, and I think I would try to invite you to do, is get 3 or 4 weird oncologists, buy them breakfast, and if possible, full Irish breakfast, spend a bit of money, and then tell them, I would like you to send me your patients. Let me see your patients. Let me see them early. Let me see them in the outpatient setting, and let's see what happens. And then they will send you the patients. This small number of colleagues will send you the patients, and they will notice that they're getting better. At that point, you will see 50 or 100 patients. Now, instead of opinions of the polyphobia and denial, you have data. And now you go to the auditorium, and now you present, and now you say, by the way, Dr. Smith and Jones were sending me patients, they're sitting there, and now you are convincing them that their life is going to be easier, their patient's life is going to be easier, nothing is broken because you have some nice data, and now you move into the most dangerous stage, that is palliative, where everybody talks about sending you patients, and now they send you dozens or hundreds of patients, and they want to set criteria. Everybody within 7 weeks of being diagnosed with advanced lung cancer needs to see supportive care, but they don't give you the resources. And then during palliative is when your program dies, because they send you so many patients and you only have so much time. And then you set the goal for how many patients can be seen, and then you see those and then you go home. Because ultimately the responsibility for those patients getting seen is the executive in charge, not yours. And finally, you move to palliative, in which you realize it, you have the criteria, you have the resources, and you match the criteria with the resources and you receive the patients. So I would propose that you take it as a change in culture, in getting the culture adopted to what we know right now. But please do not feel that just by showing the randomized controlled trials, you're going to induce adoption of this innovation. Adoption takes time, patience, and a little bit of Irish breakfast.
Thanks for that, Eduardo. I suppose one of the other key questions that's coming through is that whilst there is that hesitancy from our colleagues, professional colleagues, the same hesitancy could be also in the patient and the family to accept referral to supportive care, as we would see it, or palliative care. Is there a way of addressing that, or is it when the patient comes to us and sees the benefit and the family sees the benefit, that's our selling point?
That's a fantastic point. 50% of the patients who arrived to a supportive care center had no idea what had been sent there. Why did they send me here? I have no idea. And that has impact on them showing up, because if they don't even know why they are being sent, they might say, you know, my life is complex enough, I'm not coming to see these people. So making a point that they get either a pamphlet, a video, and the doctor who's sending them, the nurse who's sending them talks up supportive and palliative care. They say, my goodness, we're sending you such a terrific place. They're going to do such a wonderful job for your physical, emotional symptoms, function, nutrition, well-being. They're going to do so much. That's going to be so complementary and so wonderful. That's what I do when I send somebody to a surgeon. I talk them up. I say, you know what, I don't know enough about surgery, but I'm going to send you to a fantastic person who's going to really take care of you, who I really admire, and I believe that that's the wonderful person. And now the patient and the family know why they're coming, and they come with a better understanding of what can be done. So yes, doing some education of those referring doctors so that they talk up supportive care is important, and then dispelling some myths, dispelling that they're not seeing us because they're dying. They're seeing us because they have needs that we can meet and we can help them do better. Once they see us, once they get to know us, things are okay. But it's that first contact that is a challenge.
And I suppose that reflects that point you were making about integrating education into healthcare professional education, but also having colleagues rotate in for a placement makes them more open to see, yes, my patient would benefit from that referral. I'm going to hand over to Sandra, because there are a number of questions coming in live to see if we can focus on one or two of those.
Yes, to echo that point, Michael, the physician, the oncologists who rotated with us referred to us double as compared to those who did not rotate with us. Wow. So get people rotate with you, spend some time with you. It's the same as somebody who learns piano for a year or two. They're not going to be a competitor for a piano concert. They're not going to give, what they know is that playing piano is hard. They admire piano. They're going to go to a concert because they know, my goodness, piano is valuable, it's nice. Same thing. That person who rotates with you for a month is not going to stop sending you patients because they're going to treat them. Well, they're going to say, my goodness, these people do such a wonderful job. I want my patient to access these. So yes, you will double referrals if people rotate with you and then they're hired as faculty.
Sandra?
Yes.
Thanks, Eduardo.
Thank you, Michael, and thank you, Eduardo. I was just going through all the questions that are popping up suddenly, and it's very nice to see everybody engaged within this webinar. And perhaps I'm just going to randomly and time effectively choose a few of them. Some are very specific and perhaps very straightforward to answer, namely, who are the professionals in the MD outpatient clinic team, to get an better understanding on how the team is organized, what type of professionals are part of it. And then other questions more related to a referral and not really about the evidence and advantages of early referral to palliative care, but how it works. And specific questions on how to address hematological patients who have simultaneously a substantial risk to die, but also a substantial change to be cured at the same time. And based on the evidence, I would say that we all know the difficulties of referring this type of patients with this type of cancer. So perhaps I hand it over to you.
With regards to the team, it's a physician, a nurse, full-time physician and nurse. So basically people who are doing this for a job, and counselor for a job, and part-time pharmacist. And then we do have access if we need to have the chaplain and other members of the team who can become involved. But essentially, that's the core team that we have in 100%. In the rest, it's targeted. There might be chaplain, there might be OT, there might be physio, there might be other members of the team, but that's what 100% of them receive. With regards to the hematological versus solid, yes, many patients go from admission to admission to admission. So early access in some of those conditions like stem cell or leukemia might require us to see them when they're coming for admission to admission, because their care is still done in the inpatient area as compared to purely outpatient. So the measure there is getting to them wherever they happen to be at a given time. The process we have followed is the same, is to go to a group, a small group, get them motivated, sending us a patient, see the results, see how we improve the patients, and then generalize it. But yes, you're going to need to be a little bit more patient in the case of hematological. Among other things, they have a lot of fatigue, other symptoms, but have a little bit less pain. That is a sentinel symptom that sometimes helps get a patient earlier referred to you. And you had a third question in the middle, Sandra, that I'm sorry I forgot. Oh, you're muted. I'm sorry.
Okay.
That was easy.
That was easy to answer, but actually not that easy, because I was paying attention to your answer, and to tell you the truth, I also got lost in my choice. So perhaps I'm just going to choose another one, which is related to burnout. And one colleague is asking if you could give a little bit of more detail, please, on what you think is a reasonable caseload for a palliative medicine physician in an outpatient, inpatient settings, if you could elaborate a little bit on that.
Yeah, 1,200 encounters per year is a reasonable number for a clinical position that works 80% full-time. That's what we measure. That's our benchmark. We've done a little bit of publications on that. And then if you're going to do more than that, you need to get more positions to help you. If you do more, you're going to have a higher risk of burnout if you do more than those encounters. So you can discuss that. You can use that with your executive. One of the challenges for burnout is that we know that there's two components. The curative approach to burnout is the executive makes your job better. The palliative approach is self-care. Take care of yourself. And we have checklists for weekly, daily, and virtual self-care. Ideally, integrate both in yourself. Integrate advocacy with the bosses, with self-care, and then you have the curative and the palliative approach. But we know that no self-care is protective when they're killing you with extra work and referrals, and they're not respecting you anywhere in the institution, where the big specialists are the ones who treat diseases, and the ones who treat persons are treated as a second class or third class. Well, that doesn't get approached by eating well and doing meditation and doing that. That's not going to help. But take care of yourself, do the palliative, but the curative is fight. Don't make it easy. I had to do some things. For example, how do I measure my workload as compared to the medical oncologist? I went to my boss and said, well, we're coming early in the morning, we're staying until late. And my boss said, well, Eduardo, everybody's doing that. Everybody arrives at 6 o'clock in the morning and everybody leaves at 8 o'clock at night. Everybody's working so hard. And then how do I measure that? Well, the only thing I could find are parking records, because in Texas, you have to drive. So we spent 2 or 3 months with my research team going through parking records. And my research team said, Dr. Bruera, you hired us to do cancer and supportive care, and we're doing parking records here. When are we going to do something else? Well, wait. This is important. So we did parking records, and we found, after 3 months of hard work and cleaning files, I went to my boss and I said, we got something that is metaphysical that needs to be published in a journal. And he said, what is that, Eduardo? Let me tell you. Your faculty arrived at 6 o'clock in the morning, and their car arrives at 8:30. And then when they leave at 8 o'clock at night, but their car has already left at about 5. My faculty do not have that. My doctors and nurses arrive at 6:30 and their car arrives around that time, and they leave about 6:30 and their car leaves at that time. So this is an extraordinary phenomenon that we need to publish. And his answer was, shut up, Eduardo, how many positions do you need? So basically sometimes doing that numerical, looking for the evidence, not the one they want you, the one that will help you make a fair case is the one that you might need, so that the resources are matched with what you're doing. And you don't want more than the endocrinologist, gastroenterologist, or oncologist. You just want the same. That's what you're asking for.
Eduardo, can I just, on a similar theme, one of the things that's coming through is that how early is early? And if it's early, then how do you make sure that your palliative care team, who are expert in a particular specialty, are knowledgeable enough and maintaining their knowledge enough to, see that there is something reversible that would benefit from intervention?
Thank you very much, Michael. I think early to us is early advanced disease. Early disease, rarely you have somebody who's getting adjuvant therapy, a horrible mucositis, back pain. But then, as you and I were discussing offline before, you need to have a discharge date for that patient. You will help them through their terrible mucositis and their fatigue and their depression and their sadness. The therapy is gone. Now you find yourself a job. You go back to the community, to your family doctor, and now you open space for somebody else who doesn't need to be seen. So rarely you have those early patients with a lot of suffering. Most of the time is the crescendo of suffering that accompanies the diagnosis of incurable advanced disease. And then maintaining the close connection with the primary team means that we will work with them. They will be responsible for dealing with the disease management. We will help with personhood management. And then we will be able to discuss with them, because once we get in a trusting relationship, I might see a patient today, and their oncologist still has in mind that the person has a performance status of 2 and is tolerating well. And I tell them, you know what? Now they're spending all their time in the chair or in the bed, and they're starting to get a little bit confused. I think, if you don't mind, I think we need to start talking about transition to end of life. And they will say, fine, Eduardo, you gave me the number. ECOG is 4. MDAS is now 13. Please go ahead. I'll have a chat with them later on the phone. Go ahead, tell them you talked to me today. So that type of dialogue, once you build a relationship, will help when the transition needs to happen.
Thank you. I think we still have a few minutes left, and we have here a few more questions that were coming up simultaneously on the chat and now on the question and answers. And one question, and the webinar was also about the evidence that we have about the integration and early integration of palliative care. And one question is specifically about whether you think that it's ethical to conduct any more randomized control trials whereby some patients may be randomized to receive routine care. considering what we know already about early integration of palliative care?
Yeah, we're in that transition. My personal feeling is I would not do a randomized controlled trial against nothing. I would not do it. Ethically, it depends on what happens in your community, because if in your community the standard care is that nobody gets palliative care in the early stages, then you're absolutely justified in doing that study. Now, the question is, do you need to do that study, or do you need to tell your executive that your executive is behaving unethically by not allowing these patients to have access to the therapy? Great point. I would do the second. I would go to my boss and say, you know what? Patients are not having access. There's the body of evidence. Why are they not giving them access to the care they need? So that's what I would do. I would do more advocacy than an RCT. There's a huge amount of unanswered questions in our field, but the value of having palliative care is not. Now, some people tell you something that is really stupid. And my boss told me that a number of years ago, and say, Eduardo, how do we know that all those the studies, 4 or 5 studies that you're bringing are applicable to our institution? And my answer to that was, so what? Are you going to do another study to show that pembrolizumab works here because they did it in Harvard or they did it in New York? Are you going to do a study to show that radiation therapy works here? What you need is a very strong reason to say that it doesn't work here, to do a randomized control trial. If there is no clear reason why that study should not work here, then you have to accept the evidence that is published there, and nobody should distract you or attack you with I call analysis paralysis, telling you go do a study and come back in 2 or 3 years. That is part of palilalia. That's part of hurting you by sending you back and telling you go and do things, and in the meantime I will contract other people to do other things that I'm more believing in. So no, don't worry about having to do that. You know, they need to show you why there would be any justification to do this. Most of the time there isn't.
Michael, were you going to?
No, I think we have time for one more, because we're conscious that we're under strict instructions from you have another meeting, Eduardo, so we don't want to delay you. So we have time for one more.
So perhaps I'm going to go to one of the first that came up, which is specific to pain management and anxiety management in palliative care patients who previously suffered from substance abuse and also psychiatric disorders. It seems that as if they do not respond as well as expected to conventional symptom management. And what would you recommend, or what would be your advice on that?
Absolutely. I think there's no doubt that people who have a history of alcoholism or alcohol use that are positive in the CAGE-8 screening or SOAP scale, we do 100% screening in our patient population before we give them the opioids. Some of them have already been studied by someone else. That doesn't mean we're not going to give them the opioid. We're going to give them exactly the same opioid in the same dose. The difference is we're going to be watchful for non-medical opioid use behaviors. There, you know, the dog ate the pills, or I need to get more, or things are changing. The attitudes have to be of high levels of vigilance in this patient population, and then support them in an interdisciplinary, multidimensional way. We have processes for that you can look under myself and Joseph Arthur in the literature to help you guide into how to prepare for those. And the same thing happens with emotional and psychiatric distress. There's no doubt that those two, chemical coping and expression, somatic expression of suffering, are bad prognostic features of cancer pain. And we cannot treat them as an urgency. It has to be our bread and butter. We need to know how to address them with absolutely no stress. They're part of the business, and therefore we need to have processes in place. That's why having physical centers is so much better than being embedded in somebody else's center, where the priority is the cancer, the heart failure, the diabetes. Here, the person is the priority. The processes are built around the person, and the outcomes are person suffering. That's why I encourage you to get structures that will allow you to deliver better integrated palliative care.
I'm going to draw to a close, and thank you, Eduardo, so very much for your time. You are wonderful and generous with your time for sharing with us, despite a busy life in clinical and research and teaching. I'm delighted that your mum came from Cork. It is the nation's true capital, as they will tell you in Cork. And in your mother's native town, go to Mille Mille Belair. Thank you all for joining us on this webinar. Thanks to Kathy for facilitating and coordinating on behalf of our colleagues in the European Association for Palliative Care, and Sandra for co-chairing with me, and also my colleagues in the All Ireland Institute of Hospice and Palliative Care, and continued success to us on the island of Ireland for Palliative Care Week. And it's up to us now, I think, to carry on the message of integrated palliative care and that early referral, which is a benefit for those with advanced cancer, so that we can help manage their symptoms and their families and give them a good quality of life right to the very end. Many thanks, Eduardo. Have a wonderful day. Goodbye and God bless. Slán.
Thank you so much. Thanks, everybody.
Thank you.